You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about renovascular hypertension, aldosteronism, and pheochromocytoma. Recall that 20% of hypertension is secondary instead of essential. Among secondary hypertension, OSA accounts for 25 to 50%. That's obstructive sleep apnea. Renovascular disease accounts for 5 to 34%. Primary aldosteronism accounts for 8 to 20%. Drug-related causes account for 2 to 4%. Renal parenchymal disease accounts for 1%, and pheochromocytoma accounts for 0.1%. So it's relatively uncommon. In this disease, we will delve into renal artery atherosclerosis and fibromuscular dysplasia, which are examples of renovascular hypertension. We'll also talk about primary aldosteronism and pheochromocytoma. Let's start with renal artery sclerosis and fibromuscular dysplasia. You should suspect renovascular hypertension if you have failure of antihypertensives with rising blood pressure despite medication, an increase in creatinine after initiation of ACE inhibitor, progressive increase in creatinine with ischemic nephropathy, or fibromuscular dysplasia occurring in a young woman, or recurrent flash pulmonary edema or refractory CHF. 85% of renovascular hypertension is caused by atherosclerosis, which primarily affects the proximal one-third of the main renal artery. Atherosclerosis-related renovascular hypertension is primarily seen in older men with diabetes and evidence of atherosclerosis in other arterial beds such as the coronary arteries, carotid arteries, and femoral iliac or popliteal arteries. The second and less common cause of renovascular hypertension is fibromuscular dysplasia, which primarily affects women aged 20 to 60 with no family history of hypertension and mainly affects the distal two-thirds of the main renal artery and rarely involves other arterial beds. So this is a nice contrast between the two etiologies. Renovascular hypertension caused by fibromuscular dysplasia, which is the one in the distal two-thirds of the renal artery usually, is less likely to progress to complete renal artery occlusion and ischemic nephropathy compared to renovascular hypertension that's caused by atherosclerotic renal artery stenosis. That's the one that's in the proximal one-third of the renal artery usually. If kidney function worsens by more than 0.3, following initiation of an ACE or ARB in a patient with hypertension, then you need to suspect bilateral renal artery stenosis. Renal ultrasound is not great for diagnosis of renal artery stenosis due to tediousness, variability in operator skill, gas from bowels, and body habitus. CTA or MRI is better for diagnosis of renal artery stenosis. There's limited utility to plasma renin activity and renal vein sampling. The resistive index, which is PSV minus EDV all over PSV, is of limited utility as well, so you may not hear that used around. The Coral, Star, and Astral randomized controlled trials told us there is no benefit to renal artery revascularization if the blood pressure is controlled and renal function is stable. But these trials included a lot of mild disease and left out all the sick individuals with severe hypertension, declining renal function, and flash pulmonary edema. Meanwhile, registry data and clinical experience suggest that there may be benefit to renal artery revascularization. So we may see that come back in the coming years. Renal artery stenting is a good treatment for a truly ischemic kidney. Percutaneous renal angioplasty and stenting has a technical success rate of over 95%. Surgical revascularization and percutaneous angioplasty and stenting have similar degrees of blood pressure improvement and stabilization of renal function. Although percutaneous renal angioplasty and stenting improves blood pressure, complete resolution of hypertension would be unusual because many affected patients have accompanying essential hypertension or intrinsic renal disease. Only 2/3 of patients who undergo percutaneous renal artery angioplasty and stenting have a reduced requirement for antihypertensive medications. At present, Renal artery revascularization is reserved for renal artery stenosis patients with any of the following features, according to the 2022 AHA scientific statement on revascularization for renovascular disease: rapidly progressive hypertension, rapidly declining estimated glomerular filtration rate, flash pulmonary edema, or fibromuscular dysplasia with hypertension. In that situation, the fibromuscular dysplasia situation, this should be done as POBA without stenting. Patient characteristics that are suggestive of clinical benefit from revascularization are recent onset or exacerbation within 1 year of hypertension, absence of proteinuria, identifiable activation of the renin-angiotensin system, such as hyperreninemia, or if unilateral renal artery stenosis, lateralization of the renal vein renin, younger age, radiographic evidence of progressive renal artery occlusion, treatment-resistant hypertension, and angiotensin-dependent glomerular filtration rate. Renovascular hypertension from FMD, which would have bead-like appearance of renal artery in a young woman, does respond to balloon angioplasty without stent placement, as I mentioned, so it is the treatment of choice. Renal denervation for the sympathetic nerves to the kidneys for hypertension that's refractory is making a comeback in the near future as well, but at present, you don't need to know much about it. Let's move on to the next topic: hyperaldosteronism related hypertension. Primary hyperaldosteronism, also known as Conn's syndrome, is excessive production of aldosterone, a mineralocorticoid hormone, by the adrenal glands. In contrast, Cushing's syndrome is excessive production of cortisol, a glucocorticoid hormone, by the adrenal glands. Adrenal insufficiency has hyponatremia and hyperkalemia, whereas hyperaldosteronism has hypernatremia and hypokalemia. There are actually several more steps beyond elevated plasma aldosterone to renin ratio ARR greater than 20 in order to diagnose primary hyperaldosteronism. Aldosterone suppression test leads to adrenal CT, leads to adrenal venous sampling. If the plasma aldosterone to renin ratio, or ARR, is more than 20, or the plasma aldosterone itself is more than 15 nanograms per deciliter, that suggests primary hyperaldosteronism. So you confirm the diagnosis using an aldosterone suppression test, which is either an oral sodium load test or a saline infusion test. Persistent aldosterone production despite receiving an oral or intravenous sodium load confirms primary hyperaldosteronism. You're allowed to skip the aldosterone suppression test if the patient's plasma renin is so low that it is undetectable, or the plasma aldosterone is so high it is more than 30 nanograms per liter, or if there is spontaneous hypokalemia. Once primary hyperaldosteronism is confirmed, you do a CT scan of the adrenals to differentiate bilateral adrenal hyperplasia, which occurs in 60% of cases, from aldosterone-producing adrenal adenoma, which is 40% of cases. If a discrete unilateral adenoma is found, you can consider surgery. If the CT scan is normal, then you need to do adrenal venous sampling because CT has low sensitivity for small tumors. Adrenal venous sampling can differentiate between bilateral adrenal hyperplasia and unilateral adenoma or hyperplasia. If a discrete unilateral adenoma or hyperplasia is found, you can consider surgery. If bilateral adrenal hyperplasia is found, then you should stick with medical therapy using spironolactone or eplerenone. Realize that high aldosterone and low renin, indicating primary hyperaldosteronism, is only one of the etiology categories for hypertensive patients with hypokalemia. If aldosterone is high and renin is also high, that indicates secondary hyperaldosteronism, which can be from a renin-secreting tumor, renovascular hypertension, malignant hypertension, or diuretic use. If aldosterone is low and renin is low, then the cause of hypertension and hypokalemia is coming from somewhere other than the renin-aldosterone system, such as congenital adrenal hyperplasia, a deoxycorticosterone-producing adrenal tumor, Cushing's syndrome, or exogenous mineralocorticoids. Now let's move on to the next topic: pheochromocytoma. The classic triad of pheochromocytoma is episodic headaches, diaphoresis, and palpitations. These symptoms occur in paroxysms, often lasting minutes, corresponding to catecholamine surges. They have sudden severe elevations in blood pressure, often with normal blood pressure between episodes. This contrasts with other forms of secondary hypertension that tend to cause sustained hypertension. Patients with pheochromocytoma may also have orthostatic hypotension due to volume contraction and vasodilation after catecholamine surges. Hyperglycemia and weight loss due to excess catecholamines is also another manifestation of pheochromocytoma. 24-hour urine fractionated metanephrines and catecholamines and plasma fractionated metanephrines are both favored screening tests for pheochromocytoma. If those are 2 to 3 times the upper limit of normal, then get a CT scan or MRI of the abdomen. If negative, consider an MIBG scan, an octreotide scan, whole body MRI, or PET scan. If positive, then get a surgical evaluation, genetic testing, and give alpha and beta blockade prior to surgery. You can do an MIBG, which is a meta-iodobenzyl-guanidine scan, if the tumor exceeds 5 centimeters in diameter and you suspect extra-adrenal disease. MIBG resembles norepinephrine, is taken up by adrenergic tissue, and can detect tumors not detected by regular CT or MRI of the abdomen. Young patients and those with familial disorders should get an MIBG scan anyway after the CT or MRI since they are at high risk of having extra-adrenal and multiple tumors. Clinically active pheochromocytomas are typically more than 4 to 4.5 centimeters in diameter and have a high tissue density on CT scan or high intensity on T2 weighted MRI. Large tumors may have central necrosis and calcification. Before surgical removal of pheochromocytoma, you need to control blood pressure perioperatively for at least 10 to 14 days with an alpha blocker and give intravascular fluid repletion with liberal fluid and salt. You can't start beta blockade unless alpha blockade is complete. That's all for renovascular hypertension, hyperaldosteronism, and pheochromocytoma.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.